Welcome back to the 2024 California Digital Health Summit, brought to you by the California Telehealth Resource Center. I'm so glad you could join us for today's keynote session, What Every Clinician Needs to Know About Healthcare AI Use. As you know, the theme of this year's event is sustainability and equity. Digital innovation makes it happen. And now more than ever, we need a focus on the fundamentals around how we're going to transform our healthcare system. So I'm very delighted to moderate this session. My name is Sylvia Trujillo. I'm the Executive Director of CTRC. And before I jump into my introduction with the delightful presenter we're going to have, a couple of housekeeping items I want to address. So next slide, please. Just want to make sure that everyone is aware of both myself and my presenter. We are presenting for educational purposes solely. We have no relevant financial interests or arrangements with any organizations related to commercial products or services discussed during the summit today. Now, if you can move to the next slide, we'll talk about you as our participants. We want to make sure you're engaged, that you have a conversation with our presenter. So there will be time at the end of the session for Q&A. Your questions can be posted if you look at the lower half of your screen. There's a chat function where you can post your questions. And also just want to remind everyone that we are recording this session. And two more additional items I want to cover. So the next slide, we would like to thank our funders, HRSA, within the U.S. Department of Health and Human Services, that funds all of the regional TRCs and the two national ones across the country. However, the views expressed today are our own and do not represent that of either funder, which also includes HCI, which has generously supported the work of the California TRC and specifically the office, the California State Office of Rural Health. So we'd like to thank them. Next slide. The other folks we'd like to thank are the California State Rural Health Association. They've been a true partner to CTRC and we collaborate with them often, and we'll be rolling out some additional programmatic offerings with them. We also have a new partner for this conference, the Digital Health Equity Ambassador Program, a phenomenal program we'll be hearing more about later today. So with that, I would really like to start an introduction, and I don't have enough hours in the day to really extol the virtues of Dr. Marilyn Heine. She is on the American Medical Association's Board of Trustees. She is an emergency medicine trained physician as well as a hematological oncologist. So talk about a combination and the really breadth of clinical knowledge that she brings to the table. But I also want to share that in addition to the leadership positions you see listed on this slide, Dr. Heine was one of the moving forces during her time on the Council on Legislation with a small but determined group of physicians who really work with the Federation of Medicine, which includes specialty societies and state medical associations, to transform and modernize AMA's policy through a very democratic process that looks like the U.S. Congress, but does a lot more, it turns out, probably, in terms of policy making, but transformed the telehealth and digital health policy to reflect the needs of patients and clinicians using best practices and evidence-based approaches. She also led in the development of AMA's AI policy, really way before the chatter that has burst onto the scene in the last 2 years. She was leading way back in 2016 and 2017 to put together really thoughtful policies, and she was tireless and she's brilliant. And we're so delighted to have her today speak to us, not only about the work and the foundation that was laid back then, but more importantly, the advances that have been made in the intervening period to stay ahead of these transformative technologies. So with that, I'd love to turn it over to Dr. Heine for you to take it away and let us know what every clinician needs to know about healthcare AI use.
Well, thank you so much to the California Telehealth Resource Center for putting together this summit. I'm delighted to be here and represent the American Medical Association, or AMA. It is also truly an honor to have worked with Sylvia who is inspiring and instrumental in AMA's accomplishments in advancing meaningful policy and advocacy on healthcare AI. So thank you so much, Sylvia, for your most gracious introduction, but truly the sentiment is definitely mutual. On the next slide, you'll see that I have no conflicts of interest to declare. Next slide. In this session, I will introduce why and how the American Medical Association is involved in AI policy and advocacy, highlight the promise of AI applications in healthcare with example use cases, and review cautions for those who use AI in healthcare. I will also discuss policies and tools that the AMA promotes and/or is offering physicians and others to support responsible use. So first, let's get acquainted. There's a poll that we'd like to have everyone do, please. If you could just please launch the first poll. So this is a poll on what describes your primary professional role. And obviously we have a group here that is very esteemed in various areas. So thank you so much, and it's a delight to speak with you. Next slide, we have here that before we explore what clinicians need to know about AI and provide clinical cases and cautions, let me share an introduction to the AMA. The AMA is a professional association of physicians and medical students whose mission is to promote the art and science of medicine and the betterment of public health. The AMA was founded in 1847, is headquartered in Chicago, Illinois, and has an office in Washington, D.C. And uniquely, AMA policy is developed by a House of Delegates that includes representatives from over 190 organizations, including state medical associations, national medical specialty societies, and others such as federal services, including the Public Health Service. Policy adopted by the House includes our foundational policy on AI from 2018 and 2019. The AMA prefers the term augmented intelligence. We were very intentional about that, and Sylvia may recall the discussions that we had when we first launched this policy. And this is to focus on AI's assistive role to enhance and support human decision-making rather than replacing it. It is essential to have a human in the loop. The AMA establishes the AMA Code of Medical Ethics that remains relevant, including informed consent, privacy, professionalism, and other very important principles, even in a transformed era of AI. AMA publishes the Journal of the American Medical Association, which has included articles on AI in medicine. It also leads the current procedural terminology coding system that has developed classification guidance for various AI applications with important downstream impacts on valuation and payment. Next slide. As the AMA convenes the House of Delegates and collaborates with state medical associations and national medical specialty societies, the AMA represents physicians with a unified voice. The AMA strategic plan is comprised of 3 arcs. These are driving the future of medicine through medical education and professional development, improving health outcomes, and, as we will discuss today, removing obstacles that interfere with patient care. This also involves transforming digital health to optimize workflow and improve patient outcomes while mitigating risks. Principles of equity, innovation, and advocacy are central to these endeavors. Next slide. In response to the pandemic's adverse effects on physician practices, the AMA developed a recovery plan for America's physicians with 5 focus areas. 2 of these linked areas relate to this presentation today. They are transforming digital health and reducing physician burnout. The AMA is committed to ensuring that AI can meet its full potential to advance clinical care and improve clinician well-being. This may only be accomplished by ensuring that physicians engage only with AI that satisfies standards that are rigorous to meet the goals of the quintuple aim. That is, to advance health equity, enhance the patient experience, improve population health, reduce overall costs while increasing value, and ensure well-being of the care team. To learn more about the recovery plan, please see the QR code on the slide. Next slide. In a survey of nearly 1,100 physicians, including primary care and specialists, the AMA found that 41% of physicians are equally concerned and excited about increased use of AI. 30% of physicians are more excited than concerned, but for those who are cautiously optimistic or are more concerned than excited, it is important for all of us to work to help ensure that they have a sense of comfort, safety, and trust if they are to engage. So while many physicians are excited about the potential for AI, we've lived through the deployment of electronic health records. So we know what happens when end users are not involved in the design, validation, and implementation of new technology that, in the case of EHRs, converted physicians into data clerk entries, as well as worsening physician burnout and reducing patient satisfaction. So questions that physicians have about AI include, does it work? Is it clinically validated? If it works, does it work in my practice with my patient population? Does it meaningfully address something important, such as chronic disease? Does it improve or re-engineer the healthcare team to address burnout? Is it streamlined, user-centered, friction-reducing, integrated into our workflows? Does it lower overall costs? And will I be sued for using it? Let's further explore physician sentiments regarding AI by introduction of a case. Next slide. Ms. Stone has an abnormal mammogram. She is scheduled for a breast biopsy to evaluate for possible cancer. Her surgeon discusses with the pathologist the use of AI to help guide diagnosis. In a nationwide survey, what is the approximate percentage of physician respondents who thought AI would help with diagnostic ability? Poll, please. So when asking, what is the approximate percentage of physician respondents who thought AI would help with diagnostic ability, the answer, as it is in the survey, the correct answer is B. Next slide. The uses where physicians see AI as having most promise are in supporting diagnosis at 72% and supporting workflow at 69%. Next slide. Physicians' greatest enthusiasm for AI is for documentation of billing codes, medical charting, visit notes, 54%, and for automation of insurance prior authorizations to streamline that burdensome process within physician practice and care delivery environments at 48%. Next slide. Survey results show that physicians are very concerned that AI privacy will negatively impact their relationships with patients. AI tools are developed and trained using access to large data sets, yet there is little to no opportunity for a clinician to specify how secure the data entered will be or how it may be used or reused by the developer. The AMA has long held the position that the developers and implementers hold the responsibility to incorporate privacy by design techniques into their products. We think there needs to be a national discussion about consent for data use. The risk otherwise is that patients suddenly will realize that their de-identified data has become re-identified by major aggregators that they don't trust. Then their trust is broken, and patients may stop sharing important personal information that is valuable to their care. Consent should be understandable by the layperson, modifiable, granular, not blanket, rather than static and permanent. Trust is foundational to the patient-physician relationship. Much has, however, been written about AI's trust problem. A transparency mandate can mitigate risk and should help build trust. The survey results also show that physicians are very concerned about the potential liability that may arise from the use of AI. While traditional theories of physician liability will likely remain the same with respect to AI, some questions surround its use that are novel and complex. If physicians are expected to incorporate AI as part of their decision-making process, what happens if the AI that has always performed well starts to go wrong? If a physician cannot legally rely on AI technology in their decision-making process without creating new risks of liability, why would they engage with those tools at all? These questions need to be settled if we hope to see broad uptake of AI-enabled technologies. Next slide. 56% of physicians see addressing administrative burdens through automation as the biggest opportunity for AI. AI may reduce administrative burdens on physicians and provide the ability to more easily submit prior authorization and documentation requests in standardized forms that require less physician and staff time. Given the significant burden placed on physicians and administrative staff by prior authorization requests, AI could potentially provide much needed relief and help to increase professional satisfaction among the healthcare professionals. Next slide. Growing evidence links practice burdens to professional burnout for physicians and other healthcare professionals. Studies during the pandemic showed a huge spike in burnout among practicing physicians, where 63% of physicians reported burnout, and 1 in 5 said they plan to leave the profession within the next 2 years. In 2024, a survey showed burnout remains high at nearly 50%. This underscores the importance of addressing administrative burdens, something that AI, if optimally designed, developed, and deployed, has the potential to mitigate. Next slide. To highlight AI's capabilities, let's consider Mr. Baker, whose history of cigarette smoking and age meet criteria for lung cancer screening. A low-dose CT scan of the chest is performed. Initial standard review of Mr. Baker's CT scan shows no abnormality. However, AI detects an abnormality suspicious for early lung cancer. Which of the following describes this capability of AI? Poll, please. So on this poll, we'll ask which of the following describes the capability of AI. For those of you who have responded, the answer is A, identification. Next slide. A range of healthcare AI capabilities are emerging, which independently and in concert will have a significant impact on healthcare delivery. Identification and prediction have been in practice for many years. With identification, an AI tool can identify objects, patterns, and/or characteristics and increase imaging findings. In the case of Mr. Baker, who obtained a low-dose CT scan of the chest, early diagnosis may translate into improved survival from lung cancer that is often detected at later stages and has a high mortality rate. Using prediction, an AI tool can, for example, predict the risk of a patient's hospital readmission using historic data such as heart failure readmission rates and the patient's clinical data. AI can also predict adverse clinical outcomes based on vital signs and other markers. In the future, it can better support patient triage based on severity of symptoms. Translation and summarization are more recent additions to the AI landscape with the introduction of large language models. The current potential role of a translation AI tool include performing real-time clinical transcription, answering routine patient questions via chatbots, and/or drafting responses to in-basket messages, and drafting personalized patient education materials based on patient history and chart review. Use cases for the future or not yet at scale are drafting responses for patients, and also importantly, perhaps translating into an electronic healthcare record format and codifying medical information into standardized terminology that could facilitate billing and coding. Using summarization, an AI tool could review a patient's medical history extensively and rapidly, identify and summarize key information for current clinical needs. An example of suggestion is where an AI tool continually monitors a patient's blood glucose level, sends an alert to the patient and clinician when the deviations occur, and perhaps recommends a course of action such as adjusting the insulin level. Next slide. From my perspective as an emergency physician, here are two clinical use cases that are examples of AI's potential value in the emergency department. Similar to a patient whom I actually saw, this patient, whom we'll call Mrs. Roberts, presents to the ED with a cough and mild shortness of breath. Dr. Fletcher initially detects no sepsis. Dr. Fletcher's EHR is, however, integrated with an AI platform that soon detects early sepsis. Mrs. Roberts is further evaluated and managed for sepsis, a potentially critical condition. Next slide. In this use case, this is in the future, EMS transports Mr. Bird to the ED with recurrent ongoing seizures. Dr. Laird requests prior medical records to understand the patient's medical history and potential triggering factors. Dr. Laird's ED utilizes an AI tool to review Mr. Bird's extensive medical history and rapidly present information that aids in his care. Next slide. Let's consider a partial list of specialties and uses of AI on the left, which are currently being used, and on the right, which may not be currently at scale, but have potential for the future to do so. So in cardiology, AI can enhance detection of heart rhythm abnormalities and show how each blockage seen on a cardiac CT may actually impact blood flow to the heart, and may triage data from remote patient monitoring and electronic health records to identify patients at highest risk for disease progression. In dermatology, AI can help identify malignant melanoma and predict severity of psoriasis requiring more intensive treatment. For both specialties in the future, AI can aid in personalized treatment plans. Next slide. In family medicine, AI could assist with monitoring remote blood pressure readings to alert when deviations occur and support patient engagement and education through AI-driven chatbots and symptom checkers, and in the future may help support medication adherence. In neurology, AI can analyze electroencephalograms to better identify the origin of a seizure or site of abnormal circulation and identify stroke risk. In the future, it may identify early biomarkers of neurodegenerative diseases such as Alzheimer's or Parkinson's. Next slide. In obstetrics and gynecology, AI can analyze ultrasound for potential fetal abnormalities, and in the future, automatically allow for very early detection of postpartum hemorrhage risk. In ophthalmology, AI can screen for diabetic retinopathy, as was discussed here on Wednesday by Dr. Abramoff, and in the future may autonomously screen for other forms of blindness. Next slide. In pathology, AI can identify biomarkers to aid in cancer detection and in the future may standardize certain tasks that help guide treatment recommendations. Digital pathology is an area of interest for the Association of Clinical Oncology that is currently working on developing principles for responsible use of AI. In pediatrics, AI can monitor vital signs in an inpatient setting for early detection of sepsis. It can analyze inputs in the outpatient setting to predict diseases such as autism spectrum disorder, and in the future, better detect developmental delays. Next slide. In radiology, AI can help detect and classify features on imaging studies and quantify disease burden, such as in cancer, and in the future may automate image-based response criteria for oncology or conduct non-invasive analysis of cancer using imaging phenotypes. Next slide. There are many non-clinical use cases for AI across specialties. Many of these are used to some degree today, and all are likely to see an increase in utilization over the coming decade. Overall, they address access to care, administration and revenue cycle, operations, regulatory compliance and reporting, patient experience and satisfaction analysis, quality improvement and management, education, and research. Let's take a walk through a theoretical physician practice that utilizes AI for these purposes. So we'll start from the left and move over to the right. The patient's schedule for the day has been optimized. Prior authorization has been expeditious. The patient checks in through a portal at the front desk. The practice staff level has been tailored for the needs of the day. Supplies are sufficient and equipment is functional. After the clinical encounter, the clinician submits billing and coding with the use of AI with reduced claim denials, aligned with value-based payment, and adjusting for patient risk. The clinician obtains patient feedback and takes the advised steps to improve patient satisfaction. AI enables the clinician to automatically track quality outcomes, identify and address gaps in quality and health equity, and automatically ensures that the office is compliant with regulations and laws. If the office is engaged in education, such as for medical students, AI provides feedback, identifies and addresses the learner's needs. And if the office conducts clinical trials, AI helps identify and enroll patients in the research. Next slide. But there are cautions to be aware of with AI. Let's consider Mrs. Grover, who visits Dr. Norris for evaluation of a skin mole. Dr. Norris's plans to use AI to help determine if the mole is melanoma. And you'll see this lesion on the slide with the blue markings around it. So which of the following factors should Dr. Norris consider if using AI in his patient's care? Now we'll launch the next poll. So which of the following factors should Dr. Norris consider in this patient's care? Should it consider whether the algorithm was trained with data reflective of the patient's skin tone? Yes, very important, because we know in dermatology that is a significant factor in accurate diagnosis. Should he consider if the algorithm was trained using images with skin markings leading to higher false positive rates? Yes. In fact, there was a study that showed a melanoma tool revealed that in the learning set of doctors, it was more likely to put markings next to the melanoma that they were about to photograph. And in fact, the learning tool then picked up on the blue markings and said, even if there were blue markings around a benign mole, it still had a propensity to diagnose that as melanoma. So that's a significant consideration. And if the AI, should he consider also if the AI tool accepts liability, since it's a high-risk situation? Yes, the AI tool developer should accept the liability in such a circumstance. So the answer there is all of the above. Next slide. With all of the talk about ChatGPT, Dr. Suarez considers using ChatGPT to decrease the administrative burdens of generating office notes for her patients. She is aware that this technology has limitations in the clinical setting. Which of the following are among the current limitations of using ChatGPT or other large language model tools in a clinical setting or for direct patient care? Next poll. On this poll, we'll see that which of the following are among the current limitations of using ChatGPT or other large language models in the clinical setting or for direct patient care. We will consider, is there a risk of incorrect and falsified responses? Yes. Is there a risk of bias, discrimination, promoting stereotypes and inequities? Yes. Is there a risk of flawed data training? Yes. And is there impact on data privacy? Yes. So the answer is all of the above. Next slide. So generative AI tools are finding an increasing number of uses in healthcare, including assistance with administrative functions, such as generating office notes, responding to documentation requests, and generating patient messages. There has been increasing discussion about their use as clinical decision support to provide differential diagnosis, early detection and intervention, and to assist in treatment planning. While generative AI tools show tremendous promise to make a significant contribution to healthcare, there are a number of risks and limitations to consider and mitigate when using these tools in a clinical setting or for direct patient care, where the risks to patient care are especially high. Physicians who consider using a generative AI-based tool in their practice should ensure that all practice staff are educated, as well as themselves, on the risks and limitations, including patient privacy concerns, and have appropriate governance policies in place for its use prior to adoption. So let's go over some of those risks. ChatGPT, in particular, has been prone to both hallucinations or other demonstrable errors and omissions, so you always need to verify. Patients and physicians should be aware that chatbots powered by LLMs or Gen AI should provide accurate responses. However, they could provide inaccurate, misleading, or unreliable information and recommendations. So again, imperative to review. With regard to the idea of what they actually are capable of doing, they report patterns, but they don't draw inferences with judgment or nuances. They cannot understand or distinguish fact from fiction. Importantly also, there is no current regulatory structure specifically applicable to these types of AI, no ethical framework, and no widely applicable development standards to ensure their accuracy and performance. There's also little transparency or control over the ultimate use of the information entered. It's therefore susceptible to cybersecurity threats. And we know from the Change Healthcare experience that is a significant burden to physician practices and patients, something we were very committed to try and avoid at all costs in the future. LLMs may not be considered covered entities or business associates under HIPAA. So if you enter a patient's medical information into a large language model, this could violate compliance with federal or state regulations, resulting in fines or other penalties. Reliance on these tools for clinical uses could potentially lead to liability for any patient harm. I'll say that again, liability for any resulting patient harm. Large language models run the risk of potentially incorporating existing bias, returning discriminatory results, and promoting stereotypes embedded within the training data. And because these types of models cannot necessarily independently identify bias or discrimination or understand when they are perpetuating stereotypes, again, vigilance of the clinician is warranted. Training data set may be out of date or unverifiable. Let's talk just a moment more about privacy and cybersecurity. Physicians, patients, and in many cases, the AI developers don't know what happens to the information entered as prompts. Caution is warranted if one is considering entering medical records or even diagnostic images. Our recent AI principles from AMA, developed by expert physicians and AI informaticists, incorporate generative AI privacy. This includes making sure de-identified information can't be re-identified and that patients and physicians are educated and have control over the use of their information. The AMA is deeply invested in ensuring individual patient rights and protections from discrimination remain intact, that these assurances are guaranteed, and that the responsibility rests with the data holders. HIPAA cannot protect patients from the black box nature of AI, which makes the use of data opaque. AI system outputs may also include inferences that reveal personal data or previously confidential details about individuals. This can result in a lack of accountability and then a lack of trust and exacerbate data privacy concerns. Few, if any, controls are available to help users protect the data they voluntarily enter in a chatbot query. For example, if there are often no mechanisms in place for users to request the data the deletion or ensure that their inputs are not stored for use in future model training, that causes exposure. While tools designed for medical use should align with HIPAA, many, quote, HIPAA compliant, end of quote, generative tools rely on antiquated notions of de-identification. With today's advances in computing power, data can easily be re-identified. Rather than aiming to make large language models compliant with HIPAA, all healthcare AI-powered generative tools should be designed from the ground up with data privacy in mind. Threat actors could also introduce input data that compromises the overall function of the AI tool. Failure to secure and validate these inputs and corresponding data can contaminate AI models, resulting in patient harm. Strengthening AI systems against cybersecurity threats is crucial to their reliability, resiliency, and safety. On liability, there are multiple questions. What if the AI tool you rely on errors? Who's responsible? The question of physician liability for use of AI-enabled technologies presents novel and complex legal questions and poses risks to the successful clinical integration of AI-enabled technologies. It's also one of the most serious concerns for physicians when considering integration of AI into their practice. Concerns also arise for employed physicians who feel they may have no choice but to utilize the AI should the hospitals or health systems who are their employers mandate its use, or utilize an EHR system that incorporates AI-based applications as standard. The challenge for physicians regarding questions of liability for use in AI is that there is not yet any clear legal standard for determining liability. It is anticipated there will be specialty-specific standards of care going forward, and as AI continues to evolve, there may ultimately be questions regarding liability when physicians either fail to use AI or rely only on their own professional judgment, if this is something that the standard of care is to use the AI. So it could cut both ways. It should be noted that when using AI, physicians will still be subject to general legal theories regarding medical liability and negligent selection of an AI tool, including using tools outside of their intended use or intended population, or choosing a tool where there is no evidence of clinical validation, could be reasons or decisions that expose a physician to a liability claim. On regulation and the gaps. There is currently no national policy or governance structure in place to guide the development and adoption of non-device AI. Encouragement of a whole-of-government approach to implement governance policies will help to ensure that risks to consumers and patients arising from AI are mitigated to the greatest extent possible. HHS has established an AI office in March of 21 and developed a general strategy to promote the use of trustworthy AI, but has not produced a department-wide plan for the oversight of AI. CMS has some authority to regulate its use by AI by entities receiving funds from Medicare and Medicaid, including Medicare Advantage plans. And recently, CMS and the HHS Office of Civil Rights finalized its Section 1557 non-discrimination and health programs and activities rule. The FTC can regulate activities considered to be an unfair, deceptive, or abusive business practice and can enforce laws for consumer protection, but has limited authority to regulate data privacy issues that may be associated with generative AI tools, and they're under-resourced. And while the FDA regulates AI-enabled medical devices, many types of AI-enabled technologies currently fall outside the scope of FDA oversight. Furthermore, while FDA requires product labeling to provide certain information to physicians and other users, requirements for device labeling are generally considered to be less stringent and have more leeway than drug product labeling. While FDA has stated that transparency is a key priority for the agency to address, they have not yet taken additional action to update their labeling requirements for AI-enabled medical devices or put into place any additional transparency requirements for those devices. ONC's enforcement is limited and focused on EHR developers' use and integration of AIs within their federally certified EHRs. It's a major first step in requiring AI transparency, but it's still the EHR developer that is regulated with few requirements on the AI developer itself. And they will not apply to AI-enabled tools accessible through the internet, cell phones, and other devices. So we'll discuss transparency further on the next slide. For a non-AI intervention like a new drug with a randomized controlled trial that we expect to know the details about the control and intervention populations. However, we don't know that for new AI tools. We do need similar transparency. Sufficient detail should be disclosed to allow physicians to determine whether a given AI-enabled tool would reasonably apply to the individual patient they are treating. It is clear that there is an urgent need, for an additional federal action to ensure AI transparency. However, there are currently few federal requirements for transparency regarding AI. Physicians should be aware and understand that where they utilize AI-enabled tools and systems without transparency provided by the AI developer, the risks of liability for reliance on that AI will likely increase. The need for full transparency is greatest where AI-enabled systems have greater impact on direct patient care, such as AI-enabled medical devices, clinical decision support, and interaction with AI-driven chatbots. And physicians and other purchasers should consider this information when selecting the AI tools they use. They should seek appropriate information to be provided by the developers of AI so that they can best evaluate the technology to determine reported performance, intended use, intended population, and appropriateness for the tasks. Transparency should be a selling point for an AI developer. They should be encouraged to do so by physicians asking for that level of transparency and information. Training data is increasingly being treated by AI innovators as a trade secret, and we're seeing some data fiefdoms where a small number of corporations with access to rich data sites could stifle innovation. And CPT coding is distinct from payment, but has downstream effects on that. And it's very important to make these devices affordable so that they are widely available and not exacerbating health inequities. Next slide. For those who are considering using AI, more than 75% of physicians find certain information to be most helpful in deciding what to use. AMA's digital health research shows 4 key requirements for physicians to adopt AI. They need to know efficacy and features. Does it work? Does the AI do what it says it will do? Can they trust it? And what guardrails are in place? Risks or limitations. Will clinicians be liable Or will the individuals or entities that are best positioned to know the AI system risks and best positioned to avert or mitigate harm, will they take that on? That is what should happen. That must be the case. If AI liability is completely shifted to physicians, they won't use it. Real world case examples are really of value. So will it work in their practice? We can't go down the road of AI like we did with the EHRs, where they're developed to meet administrative and federal requirements. The EHRs have burdened the physicians, and we know that we should learn from that experience. Performance monitoring standards, post-marketing surveillance is very helpful. What if it stops working? What to do then? And will they receive payment? So the AMA has created a CPT code set taxonomy to provide a path for payment, and this will help stakeholders understand how AI medical services fit into their existing payment framework. Next slide. There are 4 recommended phases to engaging with AI in medical practice. First, identify the challenge and the use case you are trying to address. Then, what is available to accomplish your goal. Implement the tool and manage it. For further details, there is a resource toward the end that you can click on to get more information. Next slide. There have been numerous reports regarding the use of automated decision maker tools by payers to process claims. However, numerous reports regarding the use of these tools show a growing tendency toward inappropriate denials of care or other limitations of coverage. Reporting by ProPublica claims that tools used by Cigna denied 300,000 claims in 2 months, and the claims received an average of 1.2 seconds to review. 2 class action lawsuits were filed during 2023, charging United Healthcare and Humana with inappropriate claims denials resulting from the use of NH-Predict AI model, a product of United Healthcare subsidiary NaviHealth, and plaintiffs in those suits claimed the AI model wrongfully denied care to elderly and disabled patients enrolled in Medicare Advantage plans with both companies. Plaintiffs also claim that payers use the model despite knowing that 90% of the tools denials were faulty. So patients and physicians should be empowered to question, and we need increased regulatory oversight, transparency, and audits when payers use these systems for coverage, claim determinations, and benefit design. Next slide. So with a lagging effort toward adoption of national governance standards or oversight of AI, it is critical that the physician community engage in the development of policies to help drive advocacy, inform patient and physician education, and guide engagement with these new technologies. It is also important that the physician community help guide the development of these tools in a way that best and both meets the needs of patients and physicians, and also help define their own organization's risk tolerance, particularly where AI impacts direct patient care. AI has significant potential to advance clinical care and reduce administrative burdens, improve clinician well-being, but can only be accomplished by ensuring that physicians will engage only with the AI that satisfies these rigorous standards of the quintuple aim. Next slide. So for resources, you'll see that there are foundational principles that you can scan here on augmented intelligence, as those are policies from 2018, 2019, and then the recent principles from 2023 on development, deployment, and use. Next slide. The survey data in 2022 has shown that 9 out of 10 patients value privacy, and they believe that it is a right, and nearly 75% of people who are concerned about protecting their privacy has been highlighted in the survey. And so I encourage you to look at that by the top QR code. And also there are guidelines for digital health collection that are really important, as well as the principles for privacy. So I encourage you to look at those. We outline entities' responsibilities, patients' rights, equity considerations, and enforcement, and are steadfast that Congress must move forward with national data privacy legislation to protect all individuals, not just patients. Next slide. The Future of Health report is outstanding. It provides a wealth of information on terms, details, case uses, multiple considerations. I highly commend it to you as a resource if you're considering using AI. And the resource that's the primer on ChatGPT or generative AI is also excellent. It highlights those considerations that one must keep in mind if one is going to go down that pathway. Next slide. Education is imperative to be aware of what to do with AI, how it works, how it's ethical, and societal implications, limitations need to be considered. There are multiple resources at the AMA Ed Hub, as well as the Healthcare AI, the digital resources through a collaboration. And the next slide, you'll see there's an overall framework to promote responsible AI and use it in educational sessions as well. And then in the next slide. So in summary, the takeaways are that the AMA is involved in AI policy and advocacy to ensure it evolves to benefit patients, physicians, and healthcare community, that the applications in the healthcare show promise in multiple use cases, and it is important to recognize the cautions if you use AI in healthcare. The AMA promotes and offers an evolving range of policies and tools to support responsible use of AI by physicians and others so that we can make sure that in the deployment, the development, and the use of AI, it is done in an optimal fashion to advance healthcare for all. Next slide is my contact information, and the next is a welcome for questions. Thank you.
Fantastic. Dr. Heine, you just covered the waterfront. This is so incredible. We do have a number of questions, and I love the first one from one of our participants. And it goes back to this notion of a human in the loop when you're using a specific type of AI system, namely those that learn. So the question is, if a human is in the loop, why couldn't the system be open to new input to learn? Is it because the human is not qualified to recognize bad output? If they were qualified, wouldn't correcting bad output make the system better? So I have some opinions about this too, but I'd love to hear from you as well.
Yeah, well, that is an interesting question, but one of the concerns is one of the things that's been observed is that errors increase if it actually incorporates additional information. It's been validated with a certain set of information, and it's preferred that the validity be maintained. And so the dynamic aspect of including more information certainly appreciate, but the implications on the function of the AI tool may be less than optimal.
Right, and it does assume that a clinician doesn't make an error itself.
Yeah, right. Yeah, good point.
Assumes that the default is the validation is correct by the clinician outside of a controlled environment. And so this is a classic example where I know of at least one system, IDXDR, which I think has a different name, but it's the autonomous AI system.
Right, exactly.
Diabetic retinopathy, they actually have two systems running at once. The locked system that's already learned, it's been validated, it's gone through rigorous trials in the settings that it's expected to be implemented. And then they have a continuous learner that's continuing to learn, but that does not render an output to the clinician who is providing the service to the patient. And the clinicians can sort of compare what happened and do an ex post facto comparison of the new system to see if it's better than the old, quote unquote, old system. So yeah, that's a lovely question, very advanced question. Terrific. So I want you to think about today the OCR guidance, and you're a clinician and you've just heard many presentations related to AI, and let's say you're really sort of conceptually new to this topic, what are the three things as a clinician, if you're using clinical decision support, if you're using a digital modality like remote physiological monitoring, which may have an embedded system that is automated that may or may not use more advanced systems, what kind of action can you take today to prepare yourself to be informed and vigilant and meet your obligations under the rule, the civil rights, Office of Civil Rights rule that, end users must not use systems that discriminate and they must mitigate. So what should I do? I'm a clinician. I have no idea what any of this is. What are the three things I need to do?
Well, it's interesting. One could say the top three things that you need to do are education, education, and education. And clearly, I mean, it's education with regard to, a variety of things, right? So you have also the need to educate yourself, educate your staff, try to understand how the basically all of the AI works and what it's intended to do and what's happening. So I think it's super important that you're cognizant of the educational resources that are out there and that you can actually determine what seems right for you. But you also are really motivated, hopefully, to understand that transparency is so important. So because you want to know, is this a model that just worked in one institution, or is it something that it's going national, and is it a bespoke, or is it something that's relevant to the population that I'm seeing? And so if you are motivated to ask those questions, then hopefully the developers and those who are seeking to deploy them will also be motivated to make sure that they share that information and then meet that high standard. Like I said, transparency should be like a calling card for them. They should lead with that. And right now it's voluntary. They don't need to, but it's so important that we understand. So clearly the educational resources, those links, obviously, there's the QR codes are all there for people to look at. I really encourage people to take advantage of them because there is so much to be learned. And so I think if you take advantage of that, you'll be way ahead and be much more comfortable, but understanding what the risks and benefits are. Clearly, with regard to the whole issue of the potential for discrimination, you need to be cognizant of what that means and to make sure that you are alert to that so that when you do get the information, hopefully from a developer, you'll know what to ask for so that you could adhere to the guidelines that are out there in the final rule. So there's hopefully going to be more information coming, but we understand there's more flexibility for the individual physician practice rather than the healthcare institution. But on the other hand, that individual physician practice really isn't resourced to examine as thoroughly perhaps as a larger healthcare system. And so, we don't want to we want to make sure that there's equity and that there's fairness and that we don't exacerbate healthcare disparities just in the implementation or not of a particular AI tool.
Yeah, that's certainly a tension, right? So the least resource providers, OCR has said they're going to take a lighter touch, but those are the very providers that are disproportionately serving people that face health disparities. So there's a right answer there. Not sure that they struck the right answer. And the AMA, I know, and you are being very active in the discussion around really the alignments that need to occur. So we really only have 2 minutes. I do have one last question for you. And so it's a rapid fire answer, and then we'll wrap up. And that really is, what do you think is going to happen in 10 years with regard to clinical practice and how it will look the same or look different?
Yeah, so in 5 to 10 years, we think that the AI will augment physicians' practice of medicine. It won't replace it. Hopefully, it will be streamlining some of these administrative burdens and allow the patients to have better access, but we all, like I said, we need to be mindful of the quintuple aim, and we need to be assured that the digital health research show, as we've seen it, that the development of tools actually are ones that answer those requirements that physicians are asking. Does it work? Will they be liable? Will they receive payment? And will it work actually in their practice? So I think getting that information out will be really important. And I think that it's just a matter of assuring people that AI is a resource for them, it's a tool for them, there's great potential there, and they need to educate themselves so that they can understand best how to engage with it.
Well, you have been terrific as always, and leading to a better and more just healthcare delivery system that really meets the needs of patients where they are and supports clinicians to help achieve those aims. So we are so grateful for your time, and we thank you.
Thank you so much.